You have to review a patient who is 60 years old gentleman who comes with a limited range of motion of the left hand and the forearm. On query, he informs that this has been happening since last 8 months. And further information, he reveals that he had a saltwater catfish fin injury about 1 year back at the level of forearm. Otherwise, his past medical history is unremarkable. Physical examination reveals limited range of motion of the thumb and the small finger, and a 5 into 5 centimeter cystic swelling on the volar aspect of the wrist and distal forearm is present. There is marked swelling on the volar aspect of the thumb and tendon sheath. A lesser degree small finger involvement is also seen, with resting in slight flexion at the interphalangeal joint. Neurovascular examination is normal and there is no evidence of axillary or epitropical nodes involvement. The different diagnoses here can be neoplasm, fungal infection, myobacterial infection, or bacterial infection itself. A long undulating pattern shows it's a horseshoe abscess of non-casseating granulomatous disease secondary to mycobacteria other than tuberculosis. X-ray was done, which is positive for soft tissue swelling, but no osseous involvement. Cultures were taken, which were positive for Mycobacterium avium intercellular complex. Regarding the myobacteria, the one of the identified is Mycobacterium tuberculosis and Mycobacterium leprae. Tuberculosis, by the way, remains one of the most common pathogenous organism. Hansen disease or Mycobacterium leprae is a separate species, but leprosy is far less common. Atypical mycobacteria has traditionally means mycobacterium that is neither tuberculous or leprosy. There is a term called myobacteria other than tuberculosis, MOTT, utilized for that. Mycobacteria can be identified immediately by acid-fast stain, but most in the case, MOTT is not seen with these cultures. Current microbiologist methods takes 8 to 10 weeks to identify the slow-growing MOTT. In vitro sensitivities may not be available at least for 1 week. The MOTT infections are nowadays more commonly seen in immunocompromised patients. Contemporary cultures and diagnostic techniques have led to the recognition of several new species of non-pulmonary infections within the immunocompetent population. As the hand is the major manipulator of the environment, the hand is most likely inoculated with saprophytic bacteria. Infection occur by either cutaneous or deep pathways. Cutaneous infections are far more common. Abrasions on the extremities involving an aquatic environment, swimming pools and aquarium and fishes are the prototypical cases. These infections can spread proximally in multiple abscesses resembling spirochitosis. Deep infections in the adult population have a spectrum progressing from tensonyovitis to septic arthritis. Almost all species of MOTT can be acquired from prior trauma except Mycobacterium kansasi, which usually has no clear mode of inoculation. Mycobacterium marinum is the most common cause of MOTT infections of the upper extremity, followed in frequency by Mycobacterium kansasi. Symptoms appear slow, and only occasionally there is typical inflammatory response. A thorough remote and recent history is essential in raising suspicion of MOTT infections because they are indolent in nature and takes long to inoculate. Anyhow, in our case, we had to go on for operative intervention. An incision is made in the whole aspect of the wrist. The median nerve was identified and carefully protected. A large mass was present in the flexor tendons. The mass was opened and contained multiple rice bodies. A frozen section biopsy demonstrated presence of granulomatous disease. The evidence of granulomatous tensonyovitis indicated the need of flexor tenosynovectomy. A complete tenosynovectomy was performed with removal of diseased tissue from all flexor tendons. Thumb and little finger distal flexor tenosynovectomies were performed. Findings demonstrated horseshoe abscess and the involvement of radial ulnar bursas through a space of Perona. Patel has emphasized a simple pattern that should be followed when collecting a specimen for diagnosis of such cases. This is called 8-pack. The 8-pack consists of smears of number 1 gram stain, number 2 acid-fast stain, number 3 fungal KOH stains, and cultures, which are number 1 aerobic, number 2 anaerobic, number 3 acid-fast at 37 degrees centigrade, acid-fast at 30 degrees centigrade, and number 5 fungal. So these 8 is called 8-pack of Patel. Anyhow, in our case, the infectious disease specialist was also consulted. The patient was placed on a planned 3-day course of rifampicin with ethambutol. He developed a rash due to secondary to the ethambutol, and this medication was discontinued after 2 weeks. His wound continued to improve over the passage of time, and hand function improved with the formal rehabilitation program. Regarding the alternate method, multi-drug therapy is acceptable for initial treatment of less severe cases of granulomatous disease. The efficacy of antibiotics in MOTT infections is not clearly established. Most MOTT infections are sensitive, and at least in vitro, to the myobacterial agents, but this may not translate into viral response. In case most of the MOTT infections, surgical debridement is the primary means to effectively cure, but adjunctive treatment with antibiotics is considered appropriate. These drugs, of course, has multiple side effects and are best managed by infectious disease specialists familiar with their use.